everybody. I guess it's time to get started. Can someone just ping me if you can hear me? Okay, see, I see Ari nodding to me. Great, thank you. Hi, I'm Dr. Isabel Corcos, and I'm an epidemiologist with the County of San Diego Public Health Services Community Health Statistics Unit. I'll be moderating this panel. First, I'll introduce our speakers and say a few words about the county's programs and collaboration efforts with our tribal partners. I've also uploaded a few documents with some links and information related to this panel and other collaborative efforts. So we have two speakers today. Ms. Ormar Ayala has worked as an epidemiologist and researcher for over 20 years. Ori's work has focused on infectious diseases. She worked for the dengue branch at the CDC, where she did research on community-based interventions for dengue prevention and control. Ormar recently left Phoenix, where she worked for 10 years at Maricopa County Department of Public Health. In Phoenix, her work focused on tuberculosis research in refugee populations, outbreak investigations, preparedness and response, and syndromic surveillance strategies for mass gathering events. Ormar currently serves as the epidemiology manager for the California Tribal Epidemiology Center, CTEC, which is housed within the California Rural Indian Health Board. She'll be speaking about how local tribes have been impacted and responded to the COVID-19 pandemic. Dr. Shasta Gone is the environmental director and the Tribal Historic Preservation Officer for the Pala Band of Mission Indians in Pala, California. She will discuss the impact of climate change on tribal residents and their adaptation and mitigation efforts. In particular, she'll be talking about the Scalable San Diego Intertribal Resilience Data Development Project, which is a project that the county collaborates on. We're proud to work with our tribal nations, the Bureau of Indian Affairs and Indian Health Services, to provide health care and assist with other key service delivery, with health promotion, disaster planning and response, and other programs. Related to our panel today, the county supports COVID-19 investigations, testing sites, and assists with tribal planning for vaccine distribution and related support. We also participate in the COVID-19 community sector, which was established for cities, governments, and our sovereign tribal nations. In support of climate change adaptation and mitigation, the county and tribes work on a variety of state and local projects, sharing information and resources. We also participate in the Scalable San Diego project, as I mentioned. As part of our vision for health equity, we also publish reports, downloadable data sets and dashboards by race ethnicity, which will include information on our American Indian Alaska Native residents. Selected demographic and survey data are available, as well as medical encounter and mortality data from chronic and communicable diseases, behavioral health issues, injury, and maternal and child health. Please contact me if you'd like to know more. Finally, I want to acknowledge that my home in Scripps Ranch is on native Kumeyaay lands. If you would like to learn about the history of your home on native lands, please go to the Native Land interactive map created by Native Land Digital to learn more about territories, languages, and treaties in your area. I've included a link in one of the documents that I uploaded for this panel. If you have questions, please enter them in the Q&A box, not the chat box. Only the Q&A will work, and our speakers will be happy to respond after they do their presentations. Thank you very much, and I'll now cede the floor to our speakers. And I believe Ori is going first.
So can everybody hear me and see my slide sets? Yes?
Although we're seeing your notes, your presenter setting, not the full screen.
Oh, so here I can see the full screen in there. Okay, let me see how I fix that. Any idea how to fix that?
I think if you right click on it and do end presenter view, that should work. Or perhaps the display settings.
So let me just start again. Stop sharing and share screen. Then sorry about this, it's taking longer.
Do you just view in the slideshow?
Yeah, we're still getting
Is
your
it
notes
not?
pages.
There's an intro.
Yeah, do the hide presenter view.
There you go. Is that working?
There you go.
Bingo.
Thank you, Shasta. Okay, well, good afternoon. As Isabel indicated, my name is Aurimara Ayala, and I am the epidemiology manager for the California Tribal Epidemiology Center, or CTEC, which is housed within the California Rural Indian Health Board, or CRIB. And today I'll be talking to you about COVID-19 prevention and control efforts in tribal communities in California. I'll be describing the efforts that CTEC and CRIB have been undergoing to respond to COVID-19. So these are the topics I'm going to be covering. I'll give you a brief background on CTEC, and then I'll discuss our focus areas. I'll show you our situational reports, and then I'll talk about case investigations and contact tracing, and next steps in our efforts against COVID-19. So the California Tribal Epidemiology Center was formed in 2005. It is a statewide project that serves California tribes, tribal health programs, and urban Indian health programs. As I indicated before, it is housed within CRIB, within the Research and Public Health Department. It is staffed by one epidemiology manager, which is me, 6 epidemiologists, 4 program evaluators, 2 project coordinators, 1 research associate, and 1 outreach coordinator. We currently have 34 data sharing agreements with 3 tribes, 25 tribal health programs, and 12 urban Indian health programs. So our response to COVID-19 started back in March of 2020 when we immediately activated our internal task force, and we began conducting weekly statewide COVID-19 calls with our partners. We created a webpage for resources, and we started developing educational materials. This provides kind of an overview of what we did. So we divided our response into 4 areas: surveillance and epidemiology, communication and resources, advocacy and partnership, and trainings and planning. And I'll be focusing mostly today in surveillance and epidemiology, which is what I do. We created weekly situational reports. We receive and analyze data from the Indian Health Service. We are trying to build our syndromic surveillance strategies, and we provide technical assistance and data requests. In the communications and resources area, we provide guidance. We create educational materials that are targeted towards our tribal communities. We have some educational videos and public service announcements. We also provide coordination for personal protective equipment, and we've provided services for testing in tribal communities as well. We also assist with grant applications. A lot of what we do is building partnerships and advocacy for tribal communities in California. And so I'll show you This is kind of a list of our main partners for COVID-19. We were with the California Department of Public Health, with the California Office of Emergency Services, the Indian Health Service California Area Office, obviously with CDC, with counties, and other partners. In relation to trainings and planning, we have offered contact tracing and case investigation trainings, infection control trainings, educational webinars, and emergency preparedness plans. So anybody can request a plan, an infection control plan, or any plan related to COVID-19, and we will work with the tribal community that requests that. These are some of the posters that we created for our Stay Home, Save Lives campaign. What we did is we divided California into different regions, and then created a poster that targeted that particular region. Each poster highlights a well-known tribal leader for that area. And these posters can be found in our website, the CRIP website, and our tribal partners can go into the website and they can order the posters that they want, the number that they want, and the one that they like or prefer, and then we will mail the posters to them. So now I'm going to start talking about our data. COVID-19 Situational Report is a report that we produce Monday through Friday since back in March. It is basically descriptive epidemiologic data. It's available at our CRIPS website, but we also send a group email to all of our tribal partners, tribal health programs, clinics, and tribal communities. And the information sources are coming from the Indian Health Service, from CDC, from the California Department of Public Health, from counties, and also media for updated news and highlights. I'm going to be showing you just screenshots of different areas of the report. I will not show you the entire report because it's 10 pages, but this will give you an idea of what we're doing. So as of yesterday, we're on situation report number 182, because like I indicated before, we do that, there's this report every day. So every day we go and search for daily highlights for cases globally, for cases in the United States, for anything, any news that are related to COVID-19, any new guidance that's coming from CDC, and we'll update this section on a daily basis. As I indicated before, we have different sources of information for the data that we present. At the top here, I'm showing you the number of tested positive and negative cases by Indian Health Service area. So that's something that is we obtain from the Indian Health Service. And then at the bottom, there are two additional sources. In orange, still in orange is the Indian Health Service, and in the blue is the California Department of Public Health. So sadly, our different sources of information don't exactly match. So when you look at this, you can see that California Department of Public Health is reporting more cases than Indian Health Service, likely because they're receiving cases from other clinics outside the clinics that the Indian Health Service is covering. But right now, as of yesterday, California Department of Public Health was reporting a total of 2,711 cases among American Indian Alaska Natives. These are two more pages from our report from yesterday. This is in the left is the data that CDC provides to us. So CDC sends us a data transfer every 2 weeks of the data that's reported to them. And in blue are the number of cases among American Indian Alaska Native by age group. And in black is the number of cases among American Indian Alaska Native, the number of deaths, sorry. We also show the information by gender, and then at the bottom you can see the total cases and total deaths according to the most recent information that we have received from CDC, We have 5,162 cases and 125 deaths. Then in this map on the left, this is the number of patients that are seen at tribal health clinics in California. We divided California into regions, and we report the number of cases seen in each of the regions. And finally, we also track the websites of the different counties, and we focus on the counties that we've seen are reporting the highest number of American Indian Alaska Native cases. So this is the patient I'm showing you. And I just want to mention that we don't release any zip code data. So the lowest level that will go in the report is at the county. So we report cases worldwide, cases in the United States, cases in California, and then cases by region and by county, but then we don't report any data at any lower level than that, because the issue is that sometimes you can identify tribal communities if you do that. So we will only share information at the tribal community level if a tribe requests us to do that or gives us permission to do that. So that's why even if we have information about tribal communities, you will not see us sharing that data. So in addition to that report, which is for all of California, we also produce situation reports for tribal communities per their request. Some reports are produced weekly, others monthly. It depends on what they ask us, what is requested of us. So in the past few months, I have actually provided an extensive number of trainings on case investigations and contact tracing for tribal communities and tribal health programs. It started being a live webinar. It is now recorded and available for anybody that requested. And it's really an in-depth training that's targeted towards tribal communities. We also collaborated with the California Department of Public Health, Indian Health Service, CDC, the University of California, San Francisco, and some tribal health programs. And we created a training, a statewide California training for case investigations and contact tracing that's also available. In addition, we have created template forms for case investigations and for contact tracing. We have developed scripts for that work. We set up databases and tracking sheets. We support and provide guidance for people in training while they're doing the case investigations or the contact tracing. We also do mapping support using geographic information system mapping software. We're always available for all tribal communities in California for any phone call or email consultations regarding COVID-19 or any other health-related topic. And we follow up closely with the cases that are reported in Indian Health Service. Every time we get a report, we will check back with the clinic on that case and make sure that the case is being followed. So the work that we do is culturally based. It's an outreach, culturally based outreach approach. We believe that when you have tribal members or individuals who live within a community and who know and understand that community, if you have them doing the case investigations and the contact tracing, you're more likely to get better adherence to the quarantine and isolation guidance, better understanding of the case or the contact situation, and more likely to reach individuals. So that's why we focus on training tribal health programs and tribal communities. So we think the data can be more accurate when you're having tribal data collection more complete, ownership and control of the tribal community, and more ready access by the tribal government that allows for informed decision making. So this is a framework for case investigations and contact tracing. It actually looks different for each tribal community. So we work with the tribe, with the county department, with the tribal health clinic program. And so sometimes the tribe wants to lead their own case investigations and contact tracing. Sometimes the tribe relies on the county, or sometimes the tribe relies on the clinic. So we just work with all different groups to build those partnerships and ensure that the case investigation and contact tracing is being done. So now a little bit about syndromic surveillance. We've been doing weekly seasonal influenza syndromic surveillance reports with the Indian Health Service. The idea is for an early warning system to detect increases and outbreaks. So right now we're kind of we were using, because now we're in the middle of an outbreak again, but we were using seasonal influenza reports, kind of like an early warning or a proxy for COVID-19. We're also working with Indian Health Service to actually create a report for COVID-19. And we're trying to build partnerships with different counties across California for syndromic surveillance. And we are currently working with San Diego on this partnership. And then the next steps for us, well, we're now working with vaccines. So we're advocating to ensure equitable vaccine distribution in tribal communities. We're gathering information on facilitators and barriers for vaccine acceptance. And so the way we're doing this right now is in-depth interviews and focus groups. We may add other strategies moving forward to gather more information. And we're working on education campaign and messaging for the vaccine. This is my contact information, and thank you.
Thanks very much. People, please put your questions in the Q&A, although I see that the chat is working. So I guess that's good too. Take it away, Shasta.
All right, thank you. Just give me a moment to pick the right screen to share here. Okay. All right, and thank you, Isabel, for the introduction, and Audemars for your very informative presentation. There's some great information there on COVID, and actually some scary information too on just how great the case rates really are. And I'm going to talk a little bit about COVID today, since that was the theme of this presentation session. But I also want to talk about climate change. And it would seem that those two things aren't necessarily related, but they are related in the sense that COVID-19 is a crisis and climate change is a crisis. And they both certainly have an impact on community health. And that is doubly so, if not triply or quadruply so, in tribal nations. So I want to talk a little bit about this project that I'm going to present you some information about today. And first of all, I work for the Pala Band of Mission Indians. We are in north central San Diego County. I am the environmental director and the tribal historic preservation officer. I am not myself a tribal citizen. I am Anglo. But I want to acknowledge also that the Pala Reservation, this is Payomkowachum territory, or Luiseno. So it's important to acknowledge that these are the lands where we are. No matter where you are on Indian land. So a little bit about the project. We developed what we call the Tribal Climate Health Project, which was funded with a combination of federal funds and some local and state funding, primarily from the Bureau of Indian Affairs, and then also significantly from the National Indian Health Board through a grant that they received from the CDC. So with these different mixes of grant funding and these different partnerships, Paula partnered with a consulting firm called Prosper Sustainably, and working together, we developed an advisory group that helped us to conduct an adaptation plan and a vulnerability assessment for the Pala tribe. And we started with Pala because, of course, that's where we are. but also because we were hoping to learn from conducting our own vulnerability assessment and creating our adaptation plan, what some of the best practices were that we could pass on to our tribal colleagues in other communities. And so that's where the capacity building piece of the project came into play. We have a website, it's tribalclimatehealth.org. And on that website, you can find all sorts of different resources, including a clearinghouse of other tribes' adaptation plans, different sets of data or publications that are useful in building capacity for tribes to do their vulnerability and adaptation planning activities. We have a lot of trainings as well that we've recorded and made available online via a self-paced learning system. You can, just watch as you go. And then we have assessment plans, survey templates, and things like that to help people keep track of their own progress. And part of that is developing this data development project where we started in San Diego and are trying to gather data and develop different templates and protocols so that all tribes know where to go to get the data they need to inform their climate planning. So a little bit about California's Indian nations. Now we're doing Live Well San Diego, so I can focus on San Diego, but I think that it's important to look at the whole of the state of California and to see on the right here that there's so many different tribal nations and different cultural groups in this state. And of course, the boundaries that we see, these political boundaries of the state and of the United States and Mexico, those are artificial boundaries. Those are political boundaries. Those aren't the boundaries that tribes would have chosen. So we do have areas in San Diego, particularly where we have the Kumeyaay people who are, their lands are cut in half by the border. So just because the international border is there, it doesn't mean that we don't have Kumeyaay people in Mexico as well. And same thing when you go to the east, the Quechan go into Arizona. So it's definitely not a boundary that the tribes themselves would recognize. And if you look on the left, the graphic there shows that there are so many tribal nations in Southern California, and San Diego County in particular has 18 tribal nations, and that is more than any other county in the entire United States. So, as far as population size is concerned, and as far as land mass is concerned, or acreage, land area, we're not the biggest by any stretch of the imagination. The Navajo Nation, which is about the size of Delaware, is the largest tribal reservation, and some of the tribes in the upper Midwest and the plains have quite large reservations, measured not just in acres but in square miles. So we don't have as many people, but nonetheless, these are 18 distinct tribal nations, all separate sovereign tribal nations in San Diego County alone. And the effects of climate change on human health for these tribes and for all people is really significant. So COVID is not a climate change related infection, at least so far as we know. But there are some aspects of climate change that do have an impact on how COVID would spread. So, for example, in San Diego, we have these tremendous heat waves, and those heat waves have gotten worse. It wouldn't surprise me if there were instances where people have not had access to cooling zones because of fears that allowing people into those cooling centers would potentially put them too close in contact with one another and exacerbate the spread of COVID-19 or of SARS infection. So what we're looking at, beyond those immediate concerns with this pandemic, there's a lot of other things, other infectious diseases that climate change has an impact on. But for the most part, what we find is that people don't really think about the health impacts of climate change as the first thing that goes into their head. Usually it's more like, well, okay, it's going to get hotter, or there's going to be sea level rise, or the polar bears are going to lose their habitat. And people don't necessarily bring those ideas home and ask themselves, well, how is climate change going to affect me? And when you're talking about tribal communities, in a lot of cases, there are already underlying health conditions that can be exacerbated by the effects of climate change. So as air pollution gets worse, and those who work in this field know that high heat days increase the amount of ozone, and that has an impact on respiratory health. So asthma might be worse when it's a high heat day, and there might be problems with other respiratory diseases as well, or heat related illnesses. When people don't have access to cooling zones, or because they, like today, they lose access to power because we have a high wind event that is causing these public safety power shutoffs. And when that happens during a heat wave, people can't cool their homes. So there's, around going a whole around the wheel, you can see that there's a lot of different health effects that are related to climate change. And we know that those are only going to continue to get worse. So how does that relate to what we're doing with the Tribal Climate Health Project? We developed a framework in which we look at health as more than just the absence of medical disease. So starting with the physical and the physiological, we have, human health in terms of people's bodies, infection, chronic disease, those sorts of things. And we do want to start there. But not just tribal communities, but I think very much focus in tribal communities is their spiritual and cultural way of life and way of being. And spiritual and cultural health can be very much affected by climate change because it impacts some of the traditional resources that tribal folks want to be able to access. So, for example, oak trees are extremely important to California's tribes as a traditional subsistence food. And in times of drought, the trees get stressed, and heat stresses them as well and makes them more vulnerable to invasive pests like the gold-spotted oak borer. So you end up having a lot of oak trees, which are a sacred plant, starting to die. And then even another effect is that the acorns that are produced by those trees, because of those changes to our climate patterns, the oak trees may not produce as many acorns, or in some cases none at all, or they're only available during later in the year or earlier in the year than you're accustomed to gathering them, which means that they're not available for perhaps seasonally related tribal events. And nobody in Paula, nobody in any of the tribes in California that I've worked with use acorn as their main source of food, but it's important for special events. And they make We Wish. It's called We Wish. It's acorn mush. And if you don't have We Wish for a special event, then you've lost some of that tradition. You've lost some of that activity that contributes to your identity as a tribal member. So, and that affects who you are. It affects your spiritual and cultural well-being. And then, of course, socioeconomic health is tied up in all of this. And tribes are traditionally underserved communities. And so there's already a level of socioeconomic disparities there that is just exacerbated with climate change. And we're seeing those disparities also being exacerbated with COVID-19, with access to testing and treatment and a much higher level of infection than you are seeing in non-tribal communities. So let's talk about a little bit about the challenges of health and climate, put together. They're kind of hard to separate, but I decided for today's presentation in particular to put this map that I took from the Navajo Nation's Department of Public Health just today. So these are updated case numbers for the Navajo Nation, and they're high. Now, I know the Navajo Nation is in the Four Corners region, mostly in Arizona and New Mexico, so it doesn't relate specifically to San Diego, but it's an example that I think is important because the per capita rate of cases in the Navajo Nation is so high. And I can relate that to the case rate here in Paula. We have about 800 to 900 people who are residents on the Paula Reservation. And as of this morning, we have 102 cases. That's greater than 10%. So 1 out of every 10 people in Paula has been infected or is currently infected with COVID-19. Much higher, if that was the case for the county of San Diego, you know what, I don't do math, I can't do that in my head, but I want to say that that's like 300,000 people or 30,000 or 300,000, I don't know, but it's a lot. So that's obviously extremely worrying. And so why does that happen? Well, looking at this list that I put together, first of all, just starting with the idea that tribal communities are unique. One of the problems that we encounter is that there's a tendency to treat tribal communities as if they're all the same. So there's a notion that what would work well in Paula might also work well in Los Coyotes or in Manzanita or in Campo or in Sequan. And that's not the case. Every tribe needs to be treated as an individual. There's certainly going to be a lot of similarities, but you can't assume that what works in one place will work everywhere. We've already mentioned that tribes experience a disproportionate amount of detrimental health outcomes, both related to climate change and just in general. You have higher rates of certain diseases. There's a prevalence of obesity and obesity-related morbidities and mortalities, and diabetes rates are high. There's fairly high levels of asthma, and so those disparities, those underlying health outcomes can exacerbate the rate of infections like COVID. Same goes for water and food insecurities, which we don't have as much in Paula, but is an issue in other tribal nations. And then there's just the overall difficulty of trying to manage the differences between tribal nations and local governments like the County of San Diego or nearby cities, which for Paula would be Temecula to the north or Escondido to the south. Tribal sovereignty means that frequently tribes are not considered as part of the broader package of aid and the data that's made available. It's not always made accessible to tribes, and I'll talk about that a little more when we get to the data development part. Lack of access, and again, here's a picture of the Southern Indian Health Council sign, and you see that they serve 7 tribes in the southern part of San Diego County, and that's a lot, that for just one clinic for all 7 of those reservations. So obviously underfunded, that's I think across the board, but there's a joke about the funding for the Indian Health Service that basically goes, if you want to get really sick, make sure you do it before May, because that's when the money runs out. Now, of course, that doesn't mean that people aren't being seen, but it's more like the less critical services are going to be delayed or not made available at all because there's only money for the most critical care. And I already mentioned, just managing the tribal sovereignty piece of things with the different laws and tribal consultation and tribal consent. There are a lot of different things to consider. Just a brief example of what we're doing here in Paula to try to manage some of the effects of climate change and help the tribal community to adapt and be resilient. We identified temperature extremes, wildfire, storms and flooding, and drought as some of the most significant effects that we're likely to experience in Paula. And we're doing our best to not only fortify the tribal environment, but also to educate the people. So we have things like this extreme heat handout that is available on our website, which is the paulatribe.com. And also they are handouts that we provide for people because some of our elders still don't use the internet. And so we make sure that these are all available for folks and just remind them that there's a lot of things they can do to keep themselves safe, and then also places they can go if the heat becomes extreme. When we aren't in the midst of a pandemic, our administration building and our gym are cool zones for people who don't have air conditioning and that sort of thing. And we have all sorts of these climate change preparedness handouts that help people with wildfire, with mosquito abatement. And so education is a key part of our program. And I talked about the spiritual and emotional aspects that climate change can affect. And so we decided that we would also work on some psychosocial resilience strategies. So we developed When Our Hearts Are Happy. I won't say the words in the Cupeño language because I can't pronounce it correctly. But this is a climate resilience framework for mental health. And we made it broad enough that we hope that other tribes will be able to use it to develop their own resilience frameworks. What works, as I said before, in one tribe is not what's going to work in another tribe. And so we just provide broad ideas that people can tailor for their specific situations. But these 4 pillars on the right are really the most important for promoting what we call, the psychosocial resilience at the center, which is the calming, hope, safety, self-efficacy, and connectedness. And by improving communication and education, creating connections between people, and then delivering the resources that they need, those all strengthen psychosocial resilience. And what does any of this have to do with data? So here we are. It's the Scalable San Diego Intertribal Data Resilience Project. Now, this was stage 1 of our Intertribal Data Project. We called it Scalable because we were hoping that the initial project would be able to scale to other tribes in California and then ultimately to tribes throughout the United States. So what I put here on the right is a table from the CDC on COVID rates in the American Indian and Alaska Native nations. And this is just 23 states, which doesn't include California, but you see that there are data gaps here. And I apologize, I'm not a data scientist, so it took me a little bit to figure out what this was actually saying. But the numbers in parentheses are the percentages for how much data they were able to obtain for the American Indian and Alaska Native population. So like for hospitalization status, that status was only known for 24.2% of COVID cases in the AIAN population. So, and you see, compare that to the white non-Hispanic population where it's close to 79%, where we know the hospitalization status. So there's a lot of gaps in the data. And it's great that we have the Tribal Epidemiology Centers tracking that here in California. The data that Adamar shared with us is very, very important. But what are the tribal data needs, not just for things like COVID, but for our climate change work? Well, we need to know, first what our needs are, and then where do we even get this data in the first place? How can we access it? And what partnerships? And, working with Isabel and the County of San Diego has just been really terrific. I remember back to, I want to say it was late January or early February, we had an in-person meeting with Dr. Wilma Wooten, and which was great to be able to start talking about how can we form this partnership. And I remember I kind of cracked wise at Dr. Wooten and said, hey, thanks for making the time in the midst of getting ready for this pandemic that's going to happen. Yeah, famous last words. And the county was preparing, and we have not met since. And I don't blame her or anybody, because obviously COVID has taken all of the air. But we need to be able to form partnerships so tribes can get the data they need, because without the data, it's a lot harder for us to develop our vulnerability assessments and start to detail the solutions that we need to help manage those impacts. And then, protecting tribal information. And again, I'm glad that Adamar brought that up. The confidentiality of tribal data is really important, but it's also one of the things that's hindered us from getting the data that we need, especially when it comes to individual health. So I'm not going to read these, but this slide, it shows all of the needs that we have identified so far for our data development project. Everything from groundwater levels so that we can assess drought vulnerability to tree mortality, which I mentioned in talking about the oak trees. Can we get some information about disease vectors, ticks, mosquitoes, and rodents? What about allergies, respiratory illness? And that's really where the public health part comes into play, is we want to be able to detail at a more community specific level what kind of disease rates we're dealing with. And again, because of privacy regulations, it's not easy to get that data. Tribal communities are small enough that if you say 50% of people in Paula have diabetes, well, you're going to know who the people are basically when you've got a small, tightly knit community. So that is a little bit of a problem, but we still need to not just get access to some data, but also work with the data collecting agencies so that they are more careful about assessing who is and is not an American Indian or Alaska Native, and not just looking at somebody and making an assumption about what demographic they might belong to. Now, it might be surprising if you're looking at me on the screen with, my pale skin and my white hair. Don't be surprised, I am white. But we have tribal members in Paula who are not dissimilar to me in appearance. And so you would never know without asking whether that person identifies as an American Indian. So that's another reason that we have problems with being able to get this data. I think that there's probably a lot of local tribal folks who, when they go to emergency rooms and data is collected, they're just listed as as Hispanic or Latino. So that's something else that we really could need, is more accuracy and more specificity, so that when we do collect the data, it accurately reflects what we need. And then finally, I just want to wrap up with something I do in a lot of conversations about tribes, and that's to talk a little bit about justice, equity, diversity, and inclusion, or JEDI for short. And we're hearing a lot of conversations about JEDI because, for whatever reason, a lot of people are, for the first time, realizing that we don't have equality in this country. And for BIPOC people, or Black, Indigenous people of color, there's been a lot of attention being given to the fact that the civil rights era of the 60s and 70s did not end inequality in this country. So we're having these conversations about JEDI. But when it comes to tribes, just a couple of things to keep in mind. If you're going to work with tribes, then try to set aside your Western framework of looking at data or of looking at information, and open yourself to the idea that tribes may have different points of view. And this isn't just tribes, but any indigenous community, that for what you might see as a traceable infectious disease in a tribal cultural context might also be seen as some sort of a cultural illness as well. Things like you aren't, properly giving blessings or conducting yourself in a culturally appropriate way, and so maybe that's why you're sick. And so decentering this Western notion of what constitutes illness is important. And that goes hand in hand with centering indigenous knowledge. So what you might recognize as Lyme disease, might be called something else in a tribal context. And so be open to those different ways of knowing the world. Acknowledge historical trauma, and this is huge. Historical trauma goes back to the earliest days of colonization. And in San Diego, that's the entry of Father Serra and the Spanish missionaries in 1769, began this period of deep trauma for California's Native people, losing their lands, dying from disease. And those traumas, they're multi-generational. They can be passed on. Recognizing the inequalities, and I think we're doing a good job of that right now, but it kind of goes into the background. People will forget a little bit about these things when they leave the public eye. So just recognize that systemic inequality is pervasive in the system, and it definitely affects Native American people. Respect for tribal sovereignty, and this goes both ways. Sovereignty meaning that these are nations. No matter how small the tribe is, how limited its land base, these are still tribal sovereign nations, under the authority of the federal government, in that the federal trust relationship with tribes. But it also means recognizing that just because a tribe has sovereignty doesn't mean you can't approach them and say, hey, we want to do some work. Would you be willing to do some work with us on public health? Sovereignty doesn't mean that you should make the tribes a blank spot on your maps. It's worth it to reach out and do that work. And then finally, if you are going to work with tribes, or you want to be inclusive and have a tribal representative on your committee or on your board or come to your conference, just remember that it's not enough to check off that box and say, okay, we had tribal representation, we've done our part for JEDI. It means doing all of the things that come before that bullet point. That's really what inclusion means. That's what diversity and justice means. And if we do those things, then we can increase equity between tribes and other communities. And with that, I just want to thank you so much for giving me the opportunity to speak with you all today. And I think we have about 10 minutes left, right, Isabel, for any questions.
Unmute there for a second. Yes, please ask questions. I have one general question for Ori, which is when you were talking about facilitators and barriers to vaccine acceptance, are you seeing a pattern right now that's similar to what you're seeing we're seeing in the popular press now? Or people, do you have any sense for how good or bad that is going?
Yeah, I do. So we've heard from a couple of people that have done some informal surveys in tribal health clinics. And what we've heard is somewhere in the 20% of people have indicated that they will accept the vaccine this year, like now. 20% have said never ever, they just don't vaccinate. So those are the people that don't vaccinate for flu or any other vaccines. And then about 60% will consider it next year. But that's really informal survey. So we're planning on doing more formalized research and surveys on that. But it's looking like, yeah, pretty low. So that's why, yeah.
Okay. And Chance, I had a question, and it wasn't so much, it's pertinent to some of the things that you were discussing, but it was something that actually came up at a tribal climate change conference a couple of years ago, or I think we might have met then. And it was the idea that we don't really have to consider, we the non-tribal members don't think so much about food sovereignty and energy sovereignty as being an issue. I mean, that was kind of new. And can you comment on that?
Yeah, absolutely. So the food sovereignty movement is about tribes being able to rely on their own sources of food. And that doesn't mean that tribes are expecting to be completely self-sustaining as far as that goes, but being able to produce traditional foods and in somewhat traditional ways is really important, so that tribes that don't have access to some of the same services, or in places like the Navajo Nation that people might be really far from stores where they can get kind of prepared or ready to eat food, or even fresh produce, you are enhancing your sovereignty if you are able to support your own community with its own food. So the food sovereignty piece is a big deal, and more so for the tribes that are more remote, less so for tribes like Paula, where our tribal members can go up to Temecula or even over to Fallbrook, and they can get the foods that they need. So and honestly, I personally think that the food sovereignty movement needs to be not just a tribal movement, but a community movement, because tribes aren't the only ones. There are people in the middle of cities who don't have access to fresh food. So, food sovereignty needs to be about the ability to even go out onto your own balcony and, and pick a tomato, if you have a balcony, and if not, then having access to a community garden or, something that's a food sharing. But I think tribes are on the forefront of that.
All right. And did you have a comment about the energy?
Oh, yes, the energy.
Yeah.
Yeah, I knew there was a second piece, and I was like, what did you ask me? So the energy piece is really interesting. And some of the tribes in Southern California are actually entitled to an allocation of power from WAPA, which is the Western Area Power Authority. And for the most part, the tribes are so small here that it doesn't make a whole lot of sense to develop our own utilities. However, with the new push for renewable energy, being able to have solar power and battery backup and microgrids, there are a lot of tribes taking advantage of funding from the US Department of Energy, and Paula is one of them. We put solar on our fire station. But I know that the Rincon and San Pasqual bands, they're not just doing solar on their facilities, but they're doing their own microgrids, so that like today, when we have these public safety power shutoffs, they're still able to provide power to the critical facilities in their communities. So more tribes are starting to look at relying on their own power generation so that they're not hooked into the local utility.
Right, thank you. I don't know if there's any other questions. We have just a couple minutes. So I at least want to take the opportunity to big thank you to you, Shasta and Armar, for participating in this. I think it's been kind of, this has been great, and I feel privileged to work with you guys. And I hope that we can expand more and draw you more into our. But we did get Shasta to come and give us a lecture on site.
Oh, I forgot about that.
Yeah, that was good. That was good. And so I'm hoping that CTEC will be willing to come forth and give us some words of wisdom.
Sure.
Even virtually. I mean, you don't have to come in. You can't find parking anyway.
But Ari, thank you for what you shared, because I really learned a lot from that. And I'm sort of, it hurts my heart to hear that 20% of the people in your informal survey said they'd never get the vaccine. But at the same time, it doesn't surprise me, because the Western medical establishment has a history of doing really unethical things in indigenous communities. So, I can't blame people for not having trust. But I'll roll up my sleeve and do it right there in front of everybody if it'll encourage anyone. But I know what my friends will say. They'll say, Shasta, you're immune, you're white.
We did get a question. Edna from Alpine School District wanted to know how to get posters from your session.
Yeah, absolutely. So I think you posted in the chat the crave.org.
I did.
ihb.org.
I did.
You can go there and you'll see the COVID. There's an area where you can click on COVID resources, and you'll see the posters there, and you can just order them from there. So absolutely, I will mail them.
Great, thank you so much. And again, thank you to everyone. I think we've run out of time, so I want to make sure that I just thank you guys again, and best of health to all and to everybody who's participating in this in our panel and listening to us. Thank you so much.
Thank you.
Thank you, Isabel. Thank you, Ari.
Bye.
Bye, everyone.
Bye.